Hello, my name is NJaeger. I'm a doctoral nursing practice student, University of Massachusetts, and I will be discussing atomoxetine and presenting two case studies. Atomoxetine is a norepinephrine uptake inhibitor that increases norepinephrine and dopamine in the frontal cortex, which is involved with attention, impulsivity, and behavior. It is used in both children and adults greater than 6 years of age. It can cause CYP2D6 inhibition if a patient has this genetic mutation and can increase plasma levels of atomoxetine by up to 100%. It should not really be used in conjunction with things like bupropion, fluoxetine, or paroxetine without careful monitoring due to this potential issue. And statistically, about 7% of Caucasians are poor CYP2D6 metabolizers and may need a reduction in the dosing of atomoxetine. Dosing is 10 to 100 milligrams per day and can be given in a split dose. Potential side effects are listed here, but most are related to anticholinergic properties such as dry mouth and constipation. Also monitor for allergic reaction. The most significant issue to be worried about is possible prolongation of the QT interval and higher doses and palpitations on the cardiac side of things. And the provider should be mindful of changes in libido, erectile or ejaculation issues, or possible loss of appetite. My first case presentation is a 33-year-old Caucasian male with a history of methamphetamine abuse for 10 years. He's seeing a provider within a treatment center with a complaint of difficulty in focus and impulsivity of speech, causing him to interrupt others and create tension in groups. He has been treated for ADHD in the past as a child on stimulants and has had behavioral oppositional issues in school when he was younger. He admits to also abusing Adderall as an adult. Only other past medical history is chronic PTSD and insomnia. He takes trazodone and prazosin for sleep and nightmares related to PTSD. Family history is only significant for the mother using methamphetamine and unknown if it was during her pregnancy. And also siblings, one of them has ADHD. Social history, the patient is a smoker. He has an 11th grade education. He does not exercise regularly. He has 3 children. He is single. All diagnostic tests and labs, including the EKG, was normal. Mental status exam shows that patient will start some of his thoughts but become distracted and forget where the original thought was and have trouble recircling back. Remainder of exam is normal and is able to remember 4 words after 5 minutes. Psychiatric testing shows mild depression, a low mood disorder score, moderate generalized anxiety disorder score, an adult ADHD self-reporting scale as a moderate score. He's been treated with other psychiatric and mood stabilizers in the past, as listed, and he reached normal developmental milestones for growth and had all of his childhood vaccines. He does report methamphetamine use, casual cannabis use, and casual alcohol use. Normal physical exam. In terms of assets, this patient is currently in a controlled environment where appropriate dosing and monitoring and follow-up can occur to make sure that he's responding well to medication if prescribed. He's less likely to relapse if he's able to develop self-esteem and be able to focus on doing the work of his recovery, counseling, and other interventions needed. He also currently has insurance to pay for treatment, which has been an issue in the past. His liabilities are that he does have a history of abusing or diverting stimulant medications, that where he was previously homeless, he does not have a plan post his 90 days of residential treatment and may have limited financial resources. He also does not have a primary care provider for post follow-up treatment once he leaves residential. Differential diagnoses, I would be looking at both psychiatric and medical to make sure that he doesn't have generalized anxiety disorder or have an issue related to his chronic PTSD that may have caused brain changes, mood disorders, a sleep disorder, borderline personality disorder, dysthymia or cyclothymia. He may also be on the spectrum of autism or have a learning disability. There might be a vitamin deficiency. He might have restless legs or akathisia or obstructive sleep apnea. Case presentation number 2 is a 58-year-old male who is African American who was brought in by his wife for memory issues at home and in public with some irritability and some moodiness. The patient actually uses the phrase popcorn or Swiss cheese brain. He also has had people complain about interrupting frequently, and his wife is concerned about his behavior, and that's why the patient is seeking a consultation. Past medical history is significant for benign prostatic hyperplasia, coronary artery disease, and hypertension. There is also family history of coronary artery disease, hypertension, and stroke. He takes medication for his hypertension, his cholesterol, and his urine retention. He is a social drinker. He admits to only a few nights a week, 1 to 2 beers. Does go to church regularly. He smokes up to 1.5 packs per day for more than 10 years. He is a college graduate and a retired teacher. He does not exercise regularly. Diagnostic tests and labs, including EKG, were normal, with the exception of still having a slightly elevated total cholesterol of 208, even though he's taking atorvastatin. His mental status exam was normal, with the exception of having some frustration when he cannot find certain words that he's looking for to express his thoughts, and he was only able to remember 2 out of 4 words to repeat back after 5 minutes. He denies having any psychiatric history or diagnoses. Mild depression on his screening scale. He has a moderate screening scale score on mood disorder screening. He has mild to moderate on the anxiety scale, and the ADHD self-reporting scale is moderate. He reports having normal developmental and growth milestones, all of his childhood vaccines, and at this time a normal physical exam. His assets. He has a supportive spouse, system intact for compliance of medication and appointments. He also has a strong faith-based support system to provide counsel and respite for both the spouse and the client. He is open to seeing medical specialists, and he does have a safe home environment. However, one of the liabilities is that he doesn't appear to be opening to discussing psychiatric medications or counseling. This may be cultural because he says that he doesn't believe in that stuff or wasn't raised to talk about having any mental illness. He also hinted to possibly being mistreated by medical providers in the past. So there may be mistrust of the medical system to not be working in his best interest. And also there may be an organic degenerative brain issue that may be causing the issues here rather than ADHD. Patient 2 has a slightly different presentation of memory and mood issues, and the differential may be due to also having aging issues that are comorbid or have the need to rule out other differentials that requires follow-up testing for things like vision, hearing, brain degeneration, with ruling out things like Parkinson's or dementia. His alcohol use could be unreported, or there could be TIAs or multi-infarct memory loss from his smoking and his coronary artery disease. Patient 1 is a good candidate for atomoxetine, as his overall general health is good, and he has a documented history of attention and behavioral issues since childhood. He also will need counseling and therapeutic non-pharmacologic measures, which he can have and have access to while he's in residential treatment. He will need post-residential treatment management once he leaves the program, but his case manager could help him put that in place prior to leaving. Patient 2 is not a good candidate for multiple reasons, mostly because of his medical history. He does have benign prostatic hyperplasia, and urinary retention may worsen with atomoxetine. He may also have neurologic issues that have to do with degenerative brain changes and needs to have stroke and those things ruled out. He also has some cardiac disease, and atomoxetine is typically contraindicated with patients with cardiac disease. The treatment plan for patient 1 would be to start atomoxetine at 10 milligrams for 2 weeks and titrate to 20 milligrams if it's tolerated for 30 days. It can be split dose or moved up beyond that every 2 to 4 weeks if needed. Monthly stabilization appointments once he finds his adequate dose. He should get counseling. He should also see psychiatry that specializes in substance use disorder and ADHD. In the event he doesn't respond to non-stimulant therapy, he should have a sleep study to rule out OSA. He should have some micronutrient and vitamin testing and also be taking omega-3 fatty acid supplement. Patient 2 should have a neurology referral, audiology and vision testing. If he feels more comfortable, I would encourage him to speak with his church council regarding the use of psychiatric medications or counseling for mood stabilization. He should have further blood work. He should also be taking an omega-3 fatty acid supplement and either have an MRI of the brain or CT of the brain. So what was learned? Mostly that each patient's individual, and atomoxetine is not always the best choice for each patient, even though it's a non-stimulant. In particular, patients with a history of stimulant abuse, it could be helpful, but they do need additional support. And sometimes patients' culture, medical experiences, religious background should also be taken into consideration and carefully negotiated as to not offend the patient. Also, an ECG should be done to determine if there is a long QT interval that is already in place, or avoid atomoxetine altogether if cardiac issues have been diagnosed. And then also ruling out other mood disorders such as generalized anxiety and bipolar disorder, as they can look very similar to ADHD in its presentation. Here are my references, and I hope these case presentations have been helpful. Thank you.